See, this is what I was talking about. Rating scales are some of the metrics we use in the assessment of the progression of the disease. Generally, most commonly in the further depression, it's a HAM-D 17 or MADRS, Montgomery Asberg depression rating scale. I was wondering, why most commonly this is used and not 21? Because HAM-D 17 does not capture these four important points. These are very, very important points. These 4 points which add up, it becomes 21. These 4 points are very important because I think last time also I was talking about diurnal variation is almost a pathognomonic symptom of melancholia. And HAM-D 17 does not capture it. Second, presence of psychotic symptoms. If you rate on HAM-D 17, it does not capture psychotic symptoms, and psychotic depression gets completely, you cannot score this psychosis part component on this. I do not know why this is more frequently used and not this, whether we are missing out some of the important data. Obsessive symptoms and depersonalization, it's okay. It's not really much of a difference when it comes to that. So melancholia, you miss the important point. Psychotic depression, you miss the important point. I think that can be the problem. Here it is, NICE guidelines. Why I wanted to talk about it is that according to the NICE guidelines, for a drug to be differentiated from placebo, when you do a randomized placebo controlled trial, you start one patient on active drug, one patient on placebo. At the end of 6 weeks or 3 weeks, when you measure the HAM-D at the baseline and at the later point, if there's a difference of 3 points, suppose HAM-D is 20 for both the patients. On those on a drug, if the HAM-D is 16, and then for the other patient who on placebo it is 19, then the drug is supposed to be effective. But this is not something we look at in the clinical setup. Clinical setup, we look at a much more higher difference. Significant difference, 10 to 15 point difference, almost remission we look at. But this is what HAM-D, this is one of the points which has been criticized. Actually, to tell you, it's only 3 points, but even some of the studies, they say that that's what, like an Arvind Kash was talking about. If you combine all the published and then unpublished studies, even this is not satisfied. It's only 1.8 or something. But then even 3 points I felt is that very, very minimal kind of indicators to show the difference between an active drug and a placebo. But I just wanted to share this point with you and nothing more than that. Right, coming back to the most important thing I was talking about. This is something which is bothering me, which bothers me all the time. I don't know, from the time I looked at the study, it's always bothering me, saying that why, because of this, it's such a big problem. Study, despite the belief, right? Study shows that antidepressants and cognitive therapy fail to result in sustained positive effects. Attrition from AD treatment is significantly and unacceptably high. Substantial public health concern and scientific significance. Now, think about it for a minute. We have the current prevalence of 2.5% in MDD in India, which translates to, as I told, about 30 million or 35 million people suffering from major depressive disorder. That's a kind of a magnitude. And then we have these two, pharmacotherapy and then psychotherapy, both fail to result in positive effects. And then the attrition, people are not taking, dropout from the an antidepressant medication is significantly high. Significant prevalent morbidity in the quantum of morbidity of depression in the community. Two available tools, both antidepressants and then psychotherapy, do not show positive effect. They are not effective in the treatment. There's a significant dropout in the management of antidepressant, and especially drugs like SSRIs, which are supposed to be excellent drugs. Absolutely, it's a major public health concern. Now, what do you want us to do? There's a problem of depression in the community. You say that antidepressants show only 30%, cognitive therapy only 30%. People are not taking antidepressant. Obviously, what is going to happen to depression is a public health issue. Now, what do we do? This is, I think, that's where the discussion has come, and then I've tried to discuss it. The most important thing is that no matter how strong the evidence supporting the treatment is, it only works if the patient takes it. If the patient doesn't take it, whatever maybe you now like can conduct 1,000 RCTs, it's not going to be useful. So if attrition, if dropout, if treatment dropout is one of the major concerns, one of the major reasons why people are not responding to antidepressants in the management of MDD. I think we need to do something to improve the compliance, to reduce the attrition rate so that we can get a much more positive result. For this, maybe very unusual thing, I took the example from this, but pharmacotherapy depressing recovery rates, what are the different factors if you look at? Let us look at different factors. Number one is the diagnosis itself. I think I asked you, are you looking at MDD with the same kind of a conviction what a physician looks at typhoid? Always think, is it normal sadness? The clarity is there's a little bit of a problem. Diagnosis is not very convincing to the psychiatrist. Doctors, that's what the psychiatrist. Quite a lot of us are not convinced about the biological causation. Quite a lot of us say that the prognosis is not very good. These are all chronic disorders. These are all disability. The antidepressants do work, but not like it's a plus minus. Chloramphenicol works for typhoid. It's the kind of a confidence. There's confidence in antidepressants. Prognosis, we think that okay, prognosis is not very good. Biological causes, okay, a lot of things. The psychosocial factors, biopsychosocial, broadly we put into that and then leave it to everything. That is what one of the reasons. Doctors, our own conviction, diagnostic and then drugs themselves as a cause of inadequate treatment. Always psychotherapy is given as an alternative. When you tell a patient there is another non-drug therapy, everybody opts for it. Naturotherapy, and then swimming, and then exercise, meditation. The people who don't want to take medicines and all, is it equally effective? Thousand misconceptions, and that is why the poor compliance. When the poor compliance is poor, treatment default. This is one of the biggest problems with us. I think maybe in some of the other medication also it is there. For us, one of the biggest problems today with antidepressants is that patient walks into your clinic for the management of a diagnosed MDD. You start the medicines, you see the response after 3 weeks or 4 weeks or 5 weeks. Till then, how does the patient believe that this medicine is going to help me? How does the patient believe that in what I say? That this is one of the huge problem. That's where I said that in that Doctor's Bhagavad Gita, I want an antidepressant which works in 3 days, not after 3 weeks. So obviously when it is there, patient stops using the medicine or he takes it irregularly. Irregular medication again does not work. For us, the problem is that the so-called SSRIs have to be taken every day, day after day, continuously for 2-3 weeks. Only then we do not know why it happens. The moment you give the drug, the serotonin gets built up in the synapse, and but then the therapeutic effect takes some time. We're quite ignorant about what are the not cascading events which happens in between, but that doesn't happen. That itself is when a patient goes to the doctor, he gets a headache and then you give a tablet and the headache comes down, he believes in that. But here it doesn't happen. That's what the problem is. And, sorry, patients themselves, lack of information. And then it's both here. As I told that they're Google smart and then naive. As I told, they don't even know the difference between a psychiatrist and psychologist. And again, now like the moment you write the medicine, the next day morning you get a call saying, the doctor, I have some problem. Now, what is the problem? I have erectile dysfunction with this. The moment he says that, you know that it's not the an actual side effect, it's a presumed. He has seen, looked into the Google, and then he talking about it. So we can't stop it. So these are so many factors, all the factors. Diagnosis itself, conviction is not there. Doctors believes about this prognosis and then confidence on this. And the medication itself is as on today. Good medicines we have, but they act delayed. And then the patient. So these are all the factors, maybe the reasons for depressing. What I'm saying is that therapy is effective, but because of these factors, we are not seeing the required kind of a result. Now, I'm looking at this model. I found this model is somewhat interesting. That tuberculosis, pharmacotherapy as a model. Anti-tuberculosis regimens have an efficacy up to 95%. Fantastic. It's good. But effectiveness is average dropped down to about 70. 50-60%. They try to find out why this 95% has come down 50%. Like in our psychiatry, they found that one of the causes is that non-adherence, non-compliance. They are not taking the drugs. So, in order to improve adherence to tuberculosis treatment, WHO 1990 recommended what is called DOT, directly observed treatment strategy, at least for a period of 2 months, which I felt that it is an effective method which, if replicated in the management of MDD, which I most of the time try to do in my clinic, it should work good. Every day, directly observed treatment. Patient will get like anti-tuberculosis treatment, the combination, 3 drugs or 4 drugs, like somebody gives him every day. ASHA worker goes and gives to the patient every day. Same way, if the patient gets antidepressant drug every day for a period of not even 2 months, 1 month, I think it will do wonders. I think this DOT technique, if you follow that, it remains a standard practice even in US and Europe. Highly educated, well-developed countries, even there, you need to apply this. Patients don't take the self-medication, is not take whatever may be the reason they are not taking it. So it's a appear significantly associated with sputum severe conversion from positive to negative. That means that this non-adherence, with this using this DOT model, they are able to bring it back to from 70 to 90%, which is substantial. It's not a change of drugs, it's a change of method of administration or the way it is supervised, which is here ASHA worker goes, but for us you don't need, you caregiver gives the medicine. I'll come to that a little bit later. DOT also offers intermittent treatment regimes. I have, even in psychiatry, I have an antidepressant which I can give intermittent. It need not be given every day. Fluoxetine I can give once in 3 days. It's a long half-life of 72 hours. Or you have a long-acting preparation also. I can give once a week, once the patient is stabilized, comes out of depression, the continuation, maintenance phase. I can give, at least in some patients, where I don't have to worry about the drug interactions, fluoxetine once a week. I can give. So replicating or modeling this DOT model, will it help in the management of MDD? Will it reduce attrition rates? Will it show better efficacy in case of antidepressant treatment? This is I just want to show about the for the tuberculosis treatment. I think we all, some of the seniors here know that initially it was only treatment at sanatoriums. There was a Madras experiment. This is what it's in 1956. Sanatoriums. I think I also know about somewhere in Madanpalli there's a sanatorium where all the TB patients were sent before the advent of pharmacotherapy, because people used to think that you need a good food, better nutrition, and the fresh air and all those things which are going to help in the treatment of tuberculosis. Like what we sometimes think about psychosocial factors help in the treatment of depression. But after 5 years, followed up for 5 years, no significant difference between those who are in the sanatorium and those who are in the house. So they ended that. His tuberculosis drugs started in 40, but the first important drug in 1951. I am trying to see that, whether we can have some kind of a correlation. Some of you may laugh at it saying that, but still I am trying to see that there's something between 1951 first drug and 1950s chlorpromazine has come. About 10 million cases, and then 15% of mortality in tuberculosis. We talk about 15% of deaths, suicidal deaths in our MDD.